believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the privilege of being your host for this episode of GLI Live as part of our October is for Liver series, focusing on liver cancer. And today we will be discussing setting the standard for liver cancer imaging. And I have with me today the absolute best person to help us all understand the current and future state of best practices and standards in liver cancer imaging, Dr. Claude Sirlin, who is a professor of radiology and the director of the liver imaging group at UC San Diego, a beautiful place to practice medicine. Dr. Sirlin, welcome.
Thank you so much, Donna, for the very kind introduction. It's my pleasure to be here.
Thank you. Before we start, I just really wanted to share with you and with our audience how heroic I think you are for the following reasons. Because I came to know you as someone who would be often like the lone radiologist amongst hepatologists in several meetings. And when problems were discussed, you were always the first one to raise your hand and say, I would help solve the problem. And that is too rare, I think, in healthcare, in our world today. And just, I wanted to say, I noticed as a patient, as a leader, somebody who also has a little bit of volunteeritis, wanting to make change and wanting to make things better. But thank you for always stepping up. So I just wanted to make sure that.
That was incredibly flattering. I confess no one has ever called me a hero or heroic, so this is a first, but thank you very much for that amazing compliment.
So as we get into this, many patients, many people listening have had different types of imaging, or we've heard the word, but what is radiology and what role does it play in understanding a patient's condition?
Well, radiology comes in two flavors. There's diagnostic radiology, which are medical images such as a CT, an MRI, an X-ray, an ultrasound, which is done in essence to diagnose a condition. And then there's interventional radiology, which is kind of like surgery without a scalpel. It's surgery with a needle in which highly trained radiologists will perform mini operations through the bloodstream using catheters and needles rather than a catheter. And they can do that to treat tumors. So radiology is sort of an entire spectrum from diagnosis to treatment, workup, management.
And it has evolved a lot. I'm probably giving away my age, or at least my devotion to the history of medicine, to recognize how much radiology has come from the days when people thought they were just bombarded, or they actually were bombarded with X-rays, to now very low dose, very safe, and very, as you were starting to describe, different modalities that are being used.
Yeah, no, absolutely. And even in my career, when I first started, we did a lot of CT, we did a lot of ultrasound in the abdomen. By the way, I should say that I'm an abdominal radiologist, so that's really what I focus in, is liver disease and other conditions of the abdomen. And so when I first started my training, a lot of what we did were X-rays, ultrasound, and CT. But in the last 20, 25 years, there's been an increasing emphasis on one side, MRI, and actually something that maybe we'll talk about a little bit later is now the development of sort of point of care handheld ultrasound devices. So kind of at the opposite extremes of extremely expensive machines, but also at the other extreme, extremely inexpensive machines used for radiology.
So how actually has that evolution of technology helped to increase access to appropriate imaging?
Well, access to appropriate imaging still remains a challenge because the most advanced imaging we have are still, hospital-based ultrasound machines, hospital-based or imaging center-based CT machines, and again, imaging center or hospital-based MRI machines. However, there's an increasing recognition that we simply don't have enough ultrasound machines, MRI machines, and CT machines to image everyone in our country, and especially not everyone in the world who might benefit from imaging. And so my collaborators and I, but also other research groups, are trying to develop inexpensive point of care technologies, handheld ultrasound devices, portable MR type machines that can be distributed, to the community. So rather than having the people come to us, the idea is to have the technology go out to the people.
I think that's so exciting, and as we have, as the Global Liver Institute has facilitated some of that new mobile technology to groups around the world, the response has been amazing from both patients and practitioners who want to have this information, who need to have this information to be able to, have appropriate liver health care. But didn't have a way to get to an academic center before.
And I should be clear. These things are in development, so we do not in the year 2024 have point of care devices yet that can replace the fancy machines that we have in imaging centers. And I don't know that we'll ever completely replace them, but the idea, but my hope is in the next 5 to 10 years, we will have point of care devices that can help patients who don't live right near a CT or an MRI, for example.
So how do radiologists typically work with hepatologists? What is the workflow and the conversation like?
Well, let me take a step back and just point out that so radiology plays a role in the entire spectrum of liver health. So radiology can be used to screen for and detect the earliest manifestations of chronic liver disease well before the patient is even at risk for developing liver cancer. Conditions such as too much iron in the liver or too much fat in the liver. Imaging can also be used to detect the presence of scarring in the liver, what we call fibrosis. And imaging is often used to make the diagnosis of an advanced form of scarring, which is called cirrhosis. And once patients have cirrhosis, they are now at risk of liver cancer. And so imaging plays a role in screening the patients with liver cirrhosis for the presence of liver cancer, and also for making the diagnosis of liver cancer, staging the liver cancer, if a treatment is rendered, to assess how well the treatment is working. So imaging sort of plays a role across that entire spectrum.
I think that's so important. I want to underscore that point because our liver cancers program has had since its inception a primary goal to have people identified earlier so that either we could prevent liver cancer, which we can from many different drivers and causes, or be able to catch it in its earliest stages so that the increasing number of treatments or either and research opportunities could be available to that person.
Yeah, I think that's a really important point. Clearly, preventing cancer is the #1 solution, but we're not going to be able to prevent liver cancer in everybody. And so in those in whom it can't be prevented, it's really important to catch it early so that effective therapies can be administered and we can actually cure the cancer.
One of the challenges that I had always heard as I, came into this landscape was that it was because liver cancer does have so many different causes. And so the patients may have been treated or have come into the institution from so many different areas through hepatology, through transplant, through several through gastroenterology, through different offices coming directly from oncology, that having them, really adhere to high rates of the surveillance that is recommended under the guidelines is hard. And I heard that reported even from institutions who I've asked them, like, just contact the patients that you have now, not even asking you to find new patients, just the patients within your system. And they still found it a struggle. And so how I know that, UC San Diego has UCSD has such a strong research group, has such a strong clinical group. How do you, encourage patients to meet those surveillance goals and come in and get their imaging at 6 months intervals and really achieve that sort of best practice?
That is probably the single biggest problem that we have right now for the early detection of cancer. It's that we have recommendations for surveillance, and let me just repeat what those are, that in patients with cirrhosis and in patients with certain types of chronic hepatitis B, they should undergo surveillance every 6 months. And that surveillance right now would include an ultrasound exam and a blood test for something called alpha-fetoprotein, or AFP. And those are national guidelines, and yet nationally only about 20% of patients with cirrhosis actually undergo surveillance every 6 months, which of course means that 80% are not undergoing surveillance every 6 months. And what I see often is this. I see patients, so there's a few reasons why this happens. One is patients with cirrhosis may not know they have cirrhosis. 2, patients with cirrhosis may know they have cirrhosis but don't know they need to undergo surveillance. Or maybe they need to undergo surveillance and they know, but they just forget. And so because of that, what I see often is patients coming in with incurable cancer that is very large, has spread into the veins, potentially has already left the liver and metastasized to other organs. And this is the first time that the patient knows they have cancer. Sometimes it's even the first time they know they have liver disease. So they didn't even know they were at risk. So clearly we need to do a better job of identifying patients with cirrhosis. If they have cirrhosis, letting them know they have cirrhosis and letting them know the importance of surveillance. And then when surveillance is, recommended, to try to develop systems to help patients actually comply with the recommendations. One thing we started at UCSD about 6 months ago, this is actually a project that was started by one of our residents, is to use the electronic medical record to identify patients who are overdue for surveillance and to send notes to the provider and the patient to remind them that they need a surveillance appointment. So this was actually something that one of our residents started, and so far it's looking promising. We're very early into this process, only about 6 months, but I think innovative ideas like this are going to have to be part of the solution. Identify patients who are overdue and send reminders.
It sounds so simple, but it's so profound in its impact, and so I think that's. I love working with this next generation, and I admit that my husband, who's a physician, pointed out to me that I have a skewed view of how innovative MDs are. He's like, you meet most doctors in innovation hubs and tech incubators. So I'm like, doctors are so innovative, and so he's like, they can be, and I think ideas like this that are allowed to flourish and given support within institutions to make such an impact, I think would have to make practicing in a place like UCSD so exciting.
And it also takes champions, because this particular resident had to push really, really hard to change the system. And so it's doable, but we also need champions. And she was an example of a champion.
I think that's fantastic. I think, protection from senior people, and that encouragement, protection of the time, and giving people a chance is really important to let this innovation. I have to admit that often when I am hospitalized, residents and students and fellows tend to sort of disappear for a while as they're sitting on the couch in my room, and I'm discussing I'm picking their brains for thoughts. I figure while I'm in there, I might as well get the latest thoughts about what can be improved in healthcare from their perspective. And often they do have these great ideas. Usually, eventually, somebody comes looking for them and tells them something. But it's some of the most valuable time that I get to spend in a hospital talking to the students and interns and residents about what their fresh thoughts are about how the system can be optimized. And so they are our future guidelines.
Yes, absolutely. Well, good for you for asking the questions.
Yes, exactly. So one of the questions that is often on my mind, when we think about innovation too in imaging, is how is artificial intelligence affecting or assisting with imaging, and how is it changing or having an impact, and what do you think?
Well, clearly artificial intelligence is going to have a transformative impact, I think, for the better in diagnostic imaging, and eventually also even in interventional radiology. Starting with diagnostic imaging, what we have now is we have artificial intelligence programs running in the background that improve the quality of the images that are acquired. So whenever you acquire a medical image, there's always going to be a compromise between how long the image takes, how much quote unquote signal to noise it has in it, how many artifacts it has, et cetera. Basically the quality of the image versus how much time and how much radiation went into creating that image. So with artificial intelligence now, we can take images that without the artificial intelligence are sort of mediocre, they're kind of noisy, it's a little hard to see what's going on, and increase the clarity of the images. So I would say as of right now, that's probably the biggest advantage that AI has already had, which is improving the quality of the images. But the future is extremely bright for a much broader impact. That's just where we are right now.
Is there an opportunity for AI to increase the conversion of sort of incidentalomas, of liver cancers found in other types of abdominal screenings that, may or may not end up in the report somewhere, but are on the scans? I've heard, time and time again that somebody went in for a totally different test or intention, but that the liver cancer was found. And sometimes it's noted in the report, sometimes it's not, sometimes it's acted upon, sometimes it's not. How could AI potentially improve converting those findings into actions?
So yes, that's one possible role of AI. It's not yet implemented clinically, at least not at my institution, but the idea would be to have AI programs running in the background, identifying an unsuspected liver lesion or kidney lesion or somewhere else, and then alerting the radiologist, hey, look here. And then the radiologist would determine, oh, that's a real finding or that's not a real finding. So I think that sort of thing is going to be implemented. I'm not sure whether it's going to be this year or the next 5 years or so. I think a more challenging issue, which will come after, is not only detecting the incidental finding, but to actually try to characterize it or classify it in some way to say, okay, this is a nodule in the kidney that you weren't expecting, but this particular nodule is very likely to be benign, so it probably doesn't need anything done. Whereas this other nodule, this one is more suspicious, this one needs more workup. So that's, I think, a little bit further into the future. Now, as a liver imager, what I'm looking for in artificial intelligence, which doesn't yet exist, is I'm interested in having algorithms to help me identify the lesions that have been seen previously, help me immediately recognize how they were interpreted last time, and help me visualize clearly what changes have happened to that lesion over time. So that's just one example. I mean, I could talk at length about all my entire wish list, but to be brief, AI will have a transformative impact on medical imaging, and that impact is starting to be felt.
Okay. I'd love to hear your AI wish list. One of my law school classmates is head of the UC system data, so I would love to have that wish list, and working on that. But bringing us back to the topic of hand, and the questions that my team had put forward from us. We know that the 5-year survival rate of HCC is starting to increase. To what do we attribute that increase? That finally we're making some headway for what is attributing to the success of liver cancer efforts?
Well, I think some of it is earlier detection, and I think some of it might be more effective therapies. So for the first time, we have systemic therapies that actually are effective, and we also have interventional therapies that are more effective than before. In particular, radiation-based therapies appear to be very effective at eradicating cancer. So I think it's a combination of earlier detection as well as finally the emergence of therapies that are more effective. But what I would, back to your point from earlier, that while treatment of advanced liver cancer has improved, our best option is to detect cancer early, and an even better option is to prevent it from happening at all.
Excellent. So there has been discussions in our liver cancer councils about LRADs, liver imaging reporting and data systems. So can you tell us what those are?
Well, yes, that is something near and dear to my heart. So LIRADS, or the Liver Imaging Reporting and Data System, is something that we developed at UCSD back in 2006, really just as a local institutional way of standardizing how we interpret and report medical imaging in the context of liver cancer. And over the last 18 or 19 years, it's expanded from something that was only at UCSD into now a national system that is also used in many other parts of the world. And if you have any additional, I would be more than delighted.
I'm fascinated by anything that scales globally is really important to us. That means people found value in it, that it really resonated. Tell us more about the types of problems that it solves. And how it solves
well, let me actually start by telling you how it started. And this also gets back to your question about how radiologists and hepatologists, collaborate. So LIRAD started with a complaint. In 2006, the hepatologists and the surgeons at UCSD, called me into their office, and they had a complaint. And the complaint was that radiologists were using non-specific language, ambiguous language in reporting the imaging studies in patients at risk or with liver cancer. So for example, one person might say, cannot rule out liver cancer. Another person might say suspicious for liver cancer. Someone else might say might include liver cancer. And we had all of these different terms that the surgeons and the hepatologists couldn't understand. We as radiologists were using these terms interchangeably, sometimes changing the meaning. So I sometimes might use the same term at different times to mean different things. So bottom line is that what was coming out of our mouth was sort of gibberish. And because it wasn't actionable, they didn't know how to interpret anything that we said. So they actually said to me, we don't even care if you're right or wrong. We just want you to be clear and consistent and unambiguous. So a junior colleague and I at that time said, they're right. Our reports are gibberish. And so we decided to come up with sort of a coded way of reporting things so that our communication would be clear and unambiguous, and therefore actionable. And that was sort of the beginning of LIRADS at UCSD. And then over the last 18 years, it's expanded from something that was being developed by 2 people in one institution in San Diego in the United States to now something that's being developed and improved by over 500 radiologists, hepatologists, pathologists, different specialties throughout the world. So we have radiologists and other investigators from over 30 different countries and over 100 different institutions, all contributing to the continued progress of LIRADS.
I think that's remarkable, and that is one of the types of projects that people don't appreciate really do contribute to what high quality care is and what accuracy in medicine is, and then particularly when we start to build out either electronic health record driven or AI driven things, this diversity of terminology does really hamper the work and its significance. I think when I learned that there were 42 ways of recording you know hemoglobin or HbA1c in an electronic health record, I let out a great big sigh, and I was like, okay, how are we supposed to do interoperability? How are we supposed to have meaningful exchange if there are all these different terms that we have to map? And so that type of standardization, sounds to some, I'm like, dull. I'm like, no, that's like the secret. That's the magic. If you're looking for a magic bullet, that is one of the things that can really make so many other things possible. So
yeah, no, it's interesting. So at least in radiology, historically what we had words without a dictionary. So radiologists would use words like arterial phase hyperenhancement and washout, and these words could be used to make the diagnosis of liver cancer without a biopsy. So we can actually tell someone, you have liver cancer, using words without a definition. So I might use certain words using my internal definition. You might use words using your internal definition. We might use the same words to mean different things. So we had to standardize the meaning of the words we were using in radiology. And what I have found it to be is an actually unbelievably creative process, because it sounds, as you said, dull, standardization, but there's so much creativity in trying to figure out what is the best way of explaining something? What is the best way of doing something? What is the best way of teaching other people how to do it? So it's been a very fulfilling and creative, intellectually creative process.
And so then how does it make the leap into translating from English into other languages?
In 2011, a postdoctoral fellow from Canada visited me for a year, and as he likes to say, he's a Vietnamese Canadian of Chinese origin, and so the reason I'm mentioning all this is that after his postdoctoral scholarship with me, he became involved in LIRADS, and it was his initiative to translate LIRADS into as many languages as possible, and so he took the initiative to reach out to radiologists from China, Japan, South Korea, Italy, Spain, France, Portugal, basically almost all of the major languages spoken in the world now have translations of LIRADS into their native language, really through the leadership of this one individual. And so I'm mentioning him, and I'm mentioning my resident from before who had the initiative to start the notification system for overdue screening, to just mention that one of the beautiful things I think about LIRADS is that it allows individuals who have initiative and have vision to to blossom and to take their vision and turn it into reality.
These are exciting stories that so wonderful. It's wonderful to have this platform to be able to share. I think sometimes people don't think that what they do matters, or they think they need to be in a very high position or to have a huge organization to make a difference or to matter. And I love that these are examples of just ideas put into action and innovation applied that have made such a global difference. I may be slightly biased as a founder of a global organization, but I love hearing about people making choices
and
to make a difference.
One of the most gratifying, maybe the most gratifying thing for me is that LIRADS is not just a system, but it's using your word, it's a platform that allows people to blossom everywhere in the world, to develop their own ideas, and as you said, to take ideas and put them into action. And so we've really, it's almost been a grassroots organic thing that LIRAS has sort of expanded over time and allowed so many different people to become engaged and to have their own ideas and to take their own ideas and, as you said, convert them into action.
Excellent. So it sounds like being a liver imaging specialist is a fantastic path for someone to take. Do you have words for the next generation of folks thinking to follow in your footsteps and maybe choose a place by the beach with a lot of innovation? Seems like a smart choice too.
My main advice is follow your passion. And there will be setbacks, there will be some hiccups, there will be some speed bumps, but follow your passion. So if you have an idea, if you have a goal and you're passionate about that goal, pursue it to whatever extent you can. And feel free to reach out to me if you have an idea or you think maybe I can help you in some way. Reach out to me. No obligation. It's only if you think that it might be helpful. I don't know if it'll be possible to distribute my email at the end of this interview, but if anyone wants to reach out to me, I'm happy to help in any way that I can.
That is a wonderful offer. I'll be first in line to take you up on that. But thank you so much for this conversation today. And thank you again for all of that you do every day for patients. And so this ends this episode of GLI Live.
Thank you very much.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.